Rheumatoid arthritis is considered to be a systemic disease which is very highly characterized by symmetrical inflammation of joints. However, one has to be clear that it may involve other organ systems as well. It is the most common systemic inflammatory disease that is characterized by symmetrical joint involvement. And quite often extra-articular manifestations may also be present in a number of your patients. The chronic inflammation of synovial tissue which lines the joint capsule results in proliferation of this tissue. As the synovium continues to proliferate, it will invade the bone, and once it invades the bone and starts to destroy the cartilage, this is referred to as the pannus. This often happens to immune dysregulation, which is one of the most probable causes of rheumatoid arthritis. It may also be promoted or triggered by genetic predisposition, age-related wear and tear, hypothermia, and underlying infection. Subsequently, as the proliferation continues, the synovial lining continues to thicken and stiffen. You have ongoing proliferation, expression and upregulation of fibroblasts, and the stimulation of inflammatory cells and prostanoid production. This causes an influx of the inflammatory cells into the synovial fluid, and this induces the inflammatory cascade. The pathophysiology behind rheumatoid arthritis is much more complex, and due to the immune dysregulation, this causes an upregulation of the T and the B cells, the pro-inflammatory cytokine, particularly interleukin 1 and 6, the CD4 cells, and also other pro-inflammatory cytokines, and the stimulation of metalloproteinases, upregulation of fibroblasts, which causes also lysosomal enzyme release, which destroys the cells. Due to the immune dysregulation, you have the accumulation of T lymphocytes, which stimulates release of macrophages and releases the inflammatory cytokines, particularly interleukin 1 and interleukin 6. This releases enzymes that will cause connective tissue degradation and stimulation of B lymphocytes, and subsequently produces rheumatoid factor, RHF. One of the other diagnostic features in your patients is the production of rheumatoid factor. 70% of your patients will come back positive, and also the expression and the presence of C2 protein. The pro-inflammatory cytokines are TNF-alpha, interleukin 1, interleukin 6, and interleukin 17. The stimulation of synovial fibroblasts will cause release of matrix metalloproteinases, which causes further joint degradation. Now, typically in your patients, you must also look for extra-articular manifestations. While the typical diagnostic features will be lack of mobilization, joint stiffness, usually in the joints of the arms, wrist, and hands, for 30 minutes in the morning they may not be able to mobilize themselves. It is important to look for other extra-articular manifestations. One is the rheumatoid nodules. 20% of patients will show up with this in the extended surface of the forearms. And as this continues, you have the synovium becoming inflamed, producing excess fluid, and then it's older. The other thing is, in these patients you will see vasculitis, which is obliteration of blood vessels, particularly around the vessels of the nail beds. The next thing that is important is cardiac manifestations and pulmonary manifestations, and also splenomegaly, which is not only enlargement of the spleen, but some patients may develop thrombocytopenia. As a result, the treatment of rheumatoid arthritis requires aggressive therapy, and you need to relieve the pain. You need to immediately reduce the inflammation and the chemotaxis and the accumulation and overexpression of T and B lymphocytes, and antagonize the interleukins. You need to protect the articular structures and maintain joint function, and also control the systemic involvement and infection.